So, welcome to Hospice of Southern Illinois. October is American Pharmacist Month. We want to thank all those pharmacists out there. They're talented professionals who help us every day through education, support, and their expertise. October is also Breast Cancer Awareness Month. It's an annual campaign to raise awareness about the impact of breast cancer. So with those two things said, I welcome Jarod Payne. Jarod is a graduate from Southern Illinois University Carbondale in 2012, went on to grad school at Southern Illinois University Edwardsville, graduated with his master's in 2014. He received his license counseling social work in June of 2017 and has spent most of his career in healthcare, including almost 5 years working in the hospital setting before transitioning into hospice care, where Hospice of Southern Illinois is very benefited by his talents. So Jarod, thank you so much for being willing to speak today. I'm sure everyone's going to enjoy your presentation. Thanks, Jarod.
Thank you, Lisa and Christine. Good afternoon, everyone. We'll start here. Let me see if I can get my screen shared so you can see the presentation. All right. I think everyone should be able to see it. If not, please someone send a message and let me know. But we'll go ahead and get started, kind of talking about culture in healthcare and hospice. And so as Lisa had mentioned, a little bit of my background, just to give you a little more information. While I was at SIU Carbondale, I did complete undergrad internship in a foster care setting at a local private foster care agency, working with children and their families, supervising visits, filing paperwork, that sort of thing. Went on to grad school at Edwardsville, where I got my first taste of working in social work and healthcare. Completed my graduate level internship at the SSM Health Memory Clinic in Mount Vernon. It was during that time I was able to work with patients and families completing dementia screenings, so doing cognitive testing, psychosocial interviewing, to learn more about the patients and their families, to get an idea of what they were going through, share that information with the physician who worked at the clinic, to get them set up for treating their dementia, and working with the patients and families from that aspect. It was that opportunity that allowed me to go on to work in a healthcare setting after graduation. I worked as an inpatient social worker working on discharge planning. So that means making arrangements from durable medical equipment, home health care, nursing home placement, possible inpatient psychiatric placement, and even hospice referrals. So that opportunity allowed me to get an idea firsthand of what it's like when patients and families are brought to a discussion about hospice, what it means and what all it entails. So we'll kind of cover a little bit about what hospice is to start out, because one thing I learned during my time working in the hospice setting, in conversations both professionally and with just friends and family and people that I know, is sometimes people have a lack of knowledge when it comes to hospice care. What exactly hospice is. I've had many professional conversations where the definition of hospice and when to call in hospice when it's appropriate was a little gray area. So just to kind of start out, Medicare defines hospice as when a hospice physician and a person's own physician certify a person as terminally ill. That means that the person has a life expectancy of 6 months or less. So just a few diagnoses that can qualify for hospice include cancer, heart disease, ALS, stroke, Alzheimer's disease or dementia, Parkinson's disease, COPD, or other lung diseases. Again, it's when the life expectancy is 6 months or less. And hospice is for people who are no longer able to receive curative treatment or no longer want to pursue that curative treatment. So maybe they've gone through a course of different treatments and alternatives, and it's not changing the final outcome. Or maybe they have gone through it, it's took a toll on them. They understand that it may not cure them or may not get them back to where they once were, and they decide they want to choose a route of comfort and have a little bit maybe more quality of life over the quantity of life. And now all age groups in their final stages of life can receive hospice care. It's not just elderly, anyone that falls into a category with a terminal illness can qualify for hospice care. And one focus of hospice care is pain and symptom management with the goal of enhancing quality of life. So, you know, a person may encounter incredible pain that your typical routes aren't being managed, or what was once working no longer works. The pain gets aggressive. There may be nausea, vomiting, respiratory distress that becomes uncontrolled or more frequent. Hospice is something that can help with that. There are a team of nurses and doctors that work together with the patients and their families to address these symptoms, order medications, and make sure that they're administered in a way that patients can get relief, and hopefully enhance that quality of life. One important thing to note that I think is critical in any hospice discussion is talking about how hospice does not speed up or slow down the dying process. A person doesn't come on hospice to immediately end their life. And hospice is not a curative program, so there won't be aggressive measures in terms of treatment options, or seeking out chemotherapies, radiation treatments, that sort of thing, or even when it comes to experimental medications. So hospice does not speed up or slow down the dying process. Those on hospice are not restricted or told what they can and can't do, as long as it's safe and appropriate. So I think some people may wonder about, are they homebound? Can they still go out to restaurants or go out with their families? And of course they can. It all depends on the patient's condition what is safe and appropriate for them. One thing that comes to mind specifically is dietary restrictions. If it's safe for a person to eat and drink something, by all means, they're encouraged to have it. If they were on a low salt, no salt diet prior to coming on hospice, but they're really wanting French fries, that's something, if it's safe for them to eat physically, they're able to swallow without choking hazards, that sort of thing, aspiration risk, then by all means, they're encouraged to have those French fries. I have many patients who take trips with their families, go out on drives, go to the local Mexican restaurant. One patient in particular likes to go get her nails done. So when she's feeling like it, she's able to pack her concentrator and go out to the nail salon with her family. So you get that, get that quality of life in the sense of they're able to do more or less what they want to do as long as they feel like it. But there's that bonding time that comes with spending time with family and friends, and making those memories. And so what that kind of leads me into next really is hospice is patient-centered care. We are talking with the patient about what their expectations are, what their goals are, and what they hope to gain by their time in hospice. A lot of times they're not worried about themselves, they're worried about their families, making sure their families are taken care of, have what they need to, kind of move forward and process what is going on. Approach when it comes to hospice care. This was a graphic I found. It's Picker's 8 Principles of Patient-Centered Care, and I kind of think it's a good reference point when you're working with someone, not just in a hospice setting or healthcare, but just in any aspect of a social service. When you're dealing with someone other than yourself, you want to keep a respect for a patient's preferences. You want to have conversations with them about what their expectations might be and what they hope to gain from something, what their wishes might be. Looking at coordination and integration of care, so including the patient in that care and who they expect to be in that care as well, whether it's family members or friends. Some may not want anyone involved in it, and that's important to be respected as well. We look at information and education, so always sharing with the patient what is going on. Keeping them up to date on changes, answering any questions they may have. There's the physical comfort aspect of patient-centered care. So sometimes, patients are having a hard time processing, dealing with things. It's important that they have support, whether it be physical support or emotional support. Oftentimes that comes from relationships with family and friends. So making sure the patient has what they need when it comes to those aspects in encountering depression and anxiety, talking about what they're feeling, letting them know it's a safe place to share what's going on in their minds, what they're thinking about, and what they need from their team, to feel better. Again, there's the involvement of family and friends. It's important to have that social support, continuity in transition, and access to care. So making sure everyone's on the same page, that what one provider on the team is telling the patient, the other provider is also aware of, as well as backing up and supporting that information, and making sure the patient has access to all they need when the time comes. Nursing care, social work involvement, having someone to talk to, maybe a bath aid, maybe at one point they're able to bathe themselves, continue caring for themselves, but they may reach a point where they're not able to do that, or family's not able to do that. So making sure that they have all they need in their care. And so taking a look at the person-centered approach brings forth self-determination. So what is self-determination? That means a person makes his or her own decisions regarding how he or she wants to live their life. That means taking the time to learn about the person you're caring for, not just trying to take a cookie cutter approach. Because a person has a certain diagnosis, you may think that, okay, they may experience this level of pain after so long, or nausea, vomiting may come about at this time, and or talking about social determinants, looking at family and friends, what may impact all of that. And how are you going to know that without talking to the patient, taking the time to learn from them, listening to their stories, not just asking, the questions that you need to get for your psychosocial assessment to complete your paperwork, but, elaborating on details from their past or from past experiences, whether it be work, family, just taking that time to get to know them, but also helping them feel included in what's going on, not just coming in, checking off the boxes and moving on. You want to learn what they've been through, the life they've lived, who was a part of their life and why, and what led to that point, and what are their expectations from this point forward. When they meet you, whether it be in a healthcare setting, a hospice setting, maybe it's community mental health, or maybe it's foster care, but what are their expectations from their involvement with you? What do they hope for? And how do they plan to get that goal reached? So again, all of it comes down to listening to start out. It's a key component. Take that time to visit with them. Don't rush in and out. Help them to feel valued. This could be a stressful time in their life. I know in hospice care, big decisions were made that led up to getting involved with hospice and meeting the hospice nurse and the social worker and the whole team. So it's a stressful time. So listen to their concerns, their worries, and answer any questions they may have. Oftentimes, it's a whirlwind. It may be a blur those first few days, getting set up, meeting a whole bunch of new people, sharing their story over and over with strangers, people they don't know, that are wanting a lot of personal information or a lot of detailed information that may be hard to discuss. So just it's important to take that time to build that rapport. And again, that gathers their expectations. If they have a concern that's based on a certain area, it may be pain control. I know I encounter several patients and families who, their main concern is pain management, keeping it under control, staying comfortable, whatever it takes to get to that point. So being open and honest about what it might take, what steps are taken, how that's going to be handled, how those concerns will be addressed. And it could very well come down from pain to even just bathing. If they're not able to bathe themselves, they have an elderly partner who's not able to really do too much other than a bed bath, they may need more. Then that may be their worry. They may not want to put that stress on anyone else. And so just talking about what aid is available to them and how often and the frequency and what will be done can help to take a burden and off their shoulders and give them relief. So it's important just to talk with someone, because while you have an understanding of why you may be seeing a person, their understanding may be completely different. And so all of this can help them to feel in control of their situation and, the course that they're going to go down in their time with you. So we can move from self-determination to kind of look at some needs of the patient. I know it's very obvious, especially in a healthcare setting and hospice setting, that, there is a physical need that's going to come about. It may not be right at first. Patients tend to, be able to still live their lives. Some can drive, go out to the grocery store, do their shopping. And then some may be referred to hospice later in the disease process where they're not able to do much. So what kind of care is going to be needed physically for the patient. And that there is that expectation of physical care when you're seeking out, hospice or other health care, the physical care is going to be addressed. But when it comes to a person's health care, physical isn't the only factor. A person's emotional and social needs play a role as well. Just some things you can look at that are some questions to ask that make a difference. Does the person have stable housing? Do they have caregiving and support, whether it be family, spouse, children, brothers, sisters, parents, someone living with them, someone that lives down the street, or it may be a few hours away, but what are their options when it looks like that? Some may not have any at all outside of friends, and some that may be limited as well. So you want to kind of know ahead of time what you're looking at in terms of that kind of support. One off thing also to consider is the financial means to possibly pay for private care. In a hospice situation, if the care gets to be too much for a family member or friend, if there is someone who is able to step in and look out for a patient, or if there isn't anyone at all, what's the patient going to do moving forward, whether it be in-home private caregiving, possible nursing home placement, if it's short-term, long-term, that sort of thing. So what are their financial means to help themselves through that? So when you look at these individually, take housing, for example, what does that mean to a person for their emotional and social health? If you have stable housing, you have a place to lay your head at night, a roof over your head. So that allows for rest, being able to rest and get some form of relaxation, just to kind of recharge. If you don't know where you're going to stay, or if you're going to be able to stay in one place for too long, that added stress can really take a toll and exacerbate even the physical health conditions of a person. I kind of already mentioned looking at the caregiving and, social support side of things, having a person available. For one aspect, not just the physical care, being able to get in and out of bed or to the toilet or to the shower, but just that's part of being scared and worried. If you're going through something such as a terminal illness, thoughts are racing, lots of questions, concerns, fear of the unknown. Having someone with you, being able to, talk about those things, share your concerns, it can make a difference. Even if you don't feel comfortable sharing all the time, just having someone in the room with you to watch television with, or reminisce about stories of the past, or share a laugh, can make a big difference in how a person can feel throughout the day. And again, we've talked about, the financial means. It's stressful not knowing if you can stay at home. If a person is cognizant and aware of what is going on, aware that their family members aren't unable to care for them in their current condition, worry about what's next, what happens, how do we move forward. So, addressing those concerns as well, and what it means looking forward in terms of the care that they might need. So just a little bit, I've kind of touched on it already, what happens when those needs aren't met. You may not be able to pay your bills. That's a concern as well. Are you going to have air conditioning in the summer for those hot months, or heat for the cold months? Running water, that's a big one. Being able to clean yourself, to clean items, having drinking water. We can look at the stress that takes on the body. it can reach out to cause headaches, muscle pain and tension, fatigue, sleep problems, chest pain. All of this can exacerbate a person's terminal illness that brought them into hospice care. So when we look at that, like chest pain, for example, difficulty breathing. Okay, so you're going to have concern. Of course, if you're not feeling well, your chest is hurting, you're going to want to call for help. You're going to want to know what to do. So if social issues cause that sort of thing, how are we going to address that? And all of that, physical stress can lead to wearing a person down, maybe quicker than they might in any other situation. Being stressed all the time, worrying all the time, not sleeping, it takes a toll, and it can really bring down someone maybe faster than what a terminal illness technically could. So all of these things combined with a terminal illness can cause an additional challenge to the comfort and peace of mind when it comes to end of life care. So talking with a patient, their family, addressing some of these things, staying on top of some of these things, knowing what to look for. Sometimes patients may not feel comfortable sharing what they're going through on the social side of things. It's easy to talk about, yeah, I was running a fever, or my back really hurt, or I'm having some chest pain. It's easy to bring that up when the nurse is visiting with you, because that they can address it possibly with medications or other alternatives. But when it comes to these social needs, looking at housing, caregiving, finances, those kind of things, people are hesitant to share, whether it might be a pride situation or embarrassment. They may not want to openly talk about those things because of that, or maybe they know that or think there's not much that can be done to help them, so they don't even consider sharing it. So the important thing is to keep an eye out, look at these social situations, what's going on in the background, and having conversations with patients and their family members to ensure that all needs are being addressed, not just the physical needs of the patient. All right. And so kind of moving on, from social needs, looking at culture, humans are social creatures. Social interactions do impact our mood. So whether that's spending time with family and friends at nightly dinners, or, having a weekly lunch, making friends on the playground at school, when you were younger, or when you're starting in a new place, having lunchtime laughs with your coworkers in the break room at work, having small talk on public transportation to help pass the time from one destination to the next. All of this is part of our nature, and interacting with others. And these interactions can impact our mood. Can it make a bad day better? Or on the flip side, it can maybe take us down when we're feeling good, and everything's going our way. You may, get a smile from someone on the bus, or, just a polite word from your boss, word of encouragement that can really brighten your day. I know myself, I was nervous about this presentation and talking with you all, and speaking with some coworkers this morning, received some encouragement and kind words that really kind of boosted my spirits and calmed my nerves a little bit. So I'm appreciative of that. And it really, helps to make a difference in how I was feeling today and coming forward, making this presentation. And so, a little bit on the flip side of that, like I said, you may have an interaction that kind of brings you down a little bit. Maybe, you're doing great and somebody does kind of cut you off in traffic, or take your seat on the subway or the bus when you're trying to get home from work. And, it really can change things for you, in the blink of an eye. So all of these interactions just kind of go to show that some social relationships impact our mental health. That can, change your day. You can then move that forward into your personal relationships. Maybe you take frustrations out on, those that you live with, those that are in your home. On the flip side, you come home happy, then, you have happy interactions and have a good evening with family and friends. So just to kind of reference some studies here, the University of Texas, Deborah Umberson and Jennifer Caras Montez have an article published that with studies that show relationships have short-term and long-term effects on our health, for better and for worse. So there's evidence that social relationships benefit our health. There are studies that show that with the lowest level of involvement in social relationships, people are more likely to die than those with greater involvement. Kind of goes to show isolation. If people are left alone, or maybe they don't have someone to reach out to spend time with, or families hours away and life circumstances keep them from being able to come and be with their loved one or their relative. So that can take a toll. Depression can set in. Not having much to look forward to or any interaction, can really bring a person down. And so looking at their research and the articles that they have published, social ties reduce mortality risk among adults with documented medical conditions. So one study found that socially isolated adults with coronary artery disease had a risk of death almost 2.5 times greater than socially connected individuals. So when you think about that, that kind of goes back to what I've touched on prior to. Maybe the stress, the depression exacerbated some symptoms that otherwise may not have happened with different social interactions to help bring a person up, to help boost their spirits. So all of that is something to consider when you look at that. Social support can enhance your mental health, reduce stress, and give purpose. So when a person is diagnosed with a terminal illness and they are told there are no other treatment options, it's a stressful time, to say the least. All kinds of emotions are running, and you never know from one minute to the next what a person may be experiencing during that time. So having the social support from one individual or a group of individuals can really help impact how they are viewing their situation, and what they have to look forward to, what purpose they may feel they have moving forward with what life that they have left to live. It can be a major change going from going to work every day to being diagnosed with cancer, going through treatments, in and out of doctor's appointments, hospital settings, to being told that you have 6 months or less to live and there aren't any other treatment options for you. So making sure that there's support and social interaction that is positive can really make an impact. And at the same time, you have to make sure they are positive relationships. Not every interaction is going to be positive, but as a whole, you would want, it to be a positive relationship, because unwanted stress can lead to the psychological turmoil that wears a person down. Not sleeping leads to being weaker, not being able to get around, may not feel like eating. Well, you're not going to build strength if you're not able to eat. And all of this can exacerbate the medical conditions that can lead to discomfort and pain. Increased pain means that it's harder to manage. If you can't stay on top of that pain, if it is not controlled, it's going to be harder to get it back under control. So just thinking about things like that. And again, that peace and comfort just can allow for rest and relaxation, hopefully better pain management. And so looking at those social interactions, you have to consider the culture and ethnic background of those you're working with. Not everyone may have the same viewpoint when it comes to relationships with friends and family. Interactions may be limited, what's shared may be limited or not discussed with certain people. Things may be kept to themselves. So keeping that in mind when you look at what's going on with your patients and their families is crucial to ensuring that you are being respectful and helping them through their time that they have with you. So looking at some cultural considerations in healthcare. First, Cultural consideration is defined as the degree to which cultural awareness plays a role in interactions with particular cultural groups. So looking at those different groups and being aware that they may be different than you, or the possibility that just because you may see some things that look like you might recognize kind of how they approach life may not be the case. So it's important to talk with the person, look at their situation, and the factors that have shaped who they are. That's considering their values and beliefs, their familial and religious practices, possible language barriers, how they speak, whether it's in a native language that's different from your own, or maybe there are colloquial sayings or things like that that might not translate well. So being considerate of what that means, and also looking at their view of the system. Many times, people may feel disenfranchised by how they've been treated in the past. So that can impact their viewpoint moving forward and interactions with others when it comes to their healthcare decision-making process and how they approach that. So these thoughts can help dictate their behaviors and their interactions with others. Can be if they seek help at all, or reach out for conversation with others. Some people may not reach out, talk with the doctors. Others may just keep to themselves, talk with their family, but not want any other help. So making sure that you are aware what someone thinks or feels is important, and that may take time. You may have to build a rapport with someone. It doesn't mean that you shouldn't have the conversation. It just means it's not going to happen in a certain time frame. So looking at others, thinking about what they have to say, and just acknowledging their past experiences and working with them where they are. So I think it's important to consider that the world is full of many different people with many different beliefs. It's impossible for a healthcare worker or social worker, nurse, doctor, anyone that works with the public to know what someone's been through, and to be familiar with each of their belief systems and how that impacts their approach in life moving forward. So again, the best way to learn about a person's culture is to ask. If someone mentions to you they have certain thoughts or viewpoints on a situation, ask for clarification if they don't give it. They may kind of lead forward with a little bit, but just stop. And that could be because maybe they think you might understand what they're going through, or maybe they're not sure if you'll have a response, or they're not sure if it'll be a positive response. So ask questions to get the information about it. It helps to build rapport. And it helps, just to make sure everyone's on the same page when it comes to that person-centered approach. Get details. No questions too small. I like to kind of share with my patients and their families, if I'm not familiar, like, I'm gonna, I'm willing to ask questions, and, please share with me what information you want me to have. And then on the flip side of that, you're taking notes in your conversations with your patients and families. Do your own research, gather some information from what you can find, have a conversation with the patient to make sure you're all on the same page. Just to look that over, all of that helps someone to feel listened to and understood. It can help bridge a gap to prevent miscommunication, and everyone's aware of what expectations and what's going to happen moving forward. It also helps to build trust. Trust is crucial when it comes to your healthcare, making sure that you know what's happening, why you're being given certain medications or why not when it comes to medication you might ask for. So being open and honest, having that trust helps to bridge the gap and help everyone, have a positive experience and move forward. It also allows for opportunity to receive assistance. If someone's able to ask questions, feels comfortable, they're going to get their needs met. Making sure that they don't have unnecessary hardships, burdens, whether it be physical, social, or emotional. I know these are all very basic principles to consider. It kind of just goes back to the very beginning of asking a question when you're not aware. I think that's really important to consider. Culture is, it varies from person to person. So being able to ask questions, have conversations, helps build that rapport and helps a positive experience to come from your time together with your patients and their families. So along that line, considering the culture things, that's one of those non-physical needs in hospice care. I know, emotional aspects, spiritual aspects, it's not a decision that's made lightly. There are many factors to consider, and some that you may not think about. It's overwhelming. That's an understatement. I couldn't imagine, being told information that I have, a terminal illness, so long to live, what thoughts would go through my head. I can't even begin to fathom what I would feel during that time. So emotions are running high. There's anger, there's sadness, maybe even relief to a certain point, because you have some kind of answer to know what's going on. So when you look at that, look at those emotional side of things, you've got to consider that it's the millions of thoughts running through a person's head. They may feel numb at first, completely in shock, not acknowledge what they've been told, go into denial, not want to talk about it with their physicians or their family or their friends or loved ones, just to kind of put it in the back of their mind and not think about it. I've had many conversations when it comes to informational meetings about hospice, about that exact topic, that someone's given the information that there is no further treatment to pursue. They basically shut down that aspect and just disconnect from their life with their family, their friends, whatever it may be. They just kind of go to a place in their mind where they don't acknowledge it. So it's important to realize that will happen. So you want to think of, the appropriate questions, the right questions to ask to get the information they may need. There may be anger, and someone may be easily triggered by a conversation. So keeping that in mind when you're talking with someone, that, it's nothing personal directed at you, that there's a lot of emotions right now, and you're going to encounter all of them, and it's easy to get wrapped up in that. So just being sure to relay that you are, someone to listen and to talk to, that they can share with, that you will be there with them to support them and answer any questions. And with that being said, it can go easily from anger to hopelessness and despair. That depression, going down, to what seems like a bottomless pit. So being aware of that, what to recognize when someone is, in that depressed state or maybe an anxious state, and making sure you're having conversations, checking in with your patients and their families. You can kind of roll that into some spiritual aspects as well. You'll encounter those that have faith, and no matter how strong a faith someone might have in their, religious beliefs, they may still develop anger at a higher power, for going through something like that, or being faced with the end and not being able to change or bounce back, from that terminal diagnosis. You may encounter some that are hoping for a miracle, praying for a miracle, and they don't, and in that they may not want to have certain conversations about what the end might look like. So being respectful of those thoughts and those beliefs, and having the appropriate conversations with the patients and their families, and what that means to them, meeting them where they're at, so you address their concerns and they feel valued and listened to. One other thing, we look at the cultural aspects. So a person's identity influences how they react to the information they've been given, especially when it comes to life-changing information. They may make choices based on certain cultural beliefs that you may not be aware of, or that you may not think to consider when the time comes. So culture guides those choices. And so one aspect of culture to consider is language and communication. So how someone communicates information, how they give and receive it, whether it be through the same language that you speak. You may have different native languages. There may be sign language involved. You can look at nonverbal cues, their body language, in terms of if they're willing to talk about something, have a conversation about a certain topic. They may not feel comfortable having that conversation with you, but with someone else. You don't know. So keep that in mind. You want to ensure that someone understands what they're being told. So make sure you speak in terms that are appropriate. If someone seems to question what you mean, you say it in a different way that they might understand kind of what the meaning is. Use descriptive terms, give examples, metaphors that might help them better process what they're being told, because you never know what education level someone might be at. You never know what they've been through, what their career choice was. You may have nurses, doctors that you're caring for, so they can have a medical conversation with you using all those terms. But you may have someone who didn't finish high school, and they may never have had interaction that led them to know much about healthcare terms and what all of it means. So being aware of that, making sure that they understand things and are making decisions appropriately, and not because it's something they feel like they should do because you're there and asking them questions. So looking at that nonverbal communication, eye contact is huge. Some cultures expect eye contact. Some do not give eye contact. It may be based on male and female genders. They may not feel comfortable making eye contact. It may not mean that they're not listening or that they're, disconnected from your conversation. So be aware of that and what that might mean in building rapport with someone and giving them the support they need. Another form we look at is there, are their arms crossed? Are they facing forward, engaged with you, or are they completely disconnected? Looking at that may help you decide if you're going to pursue a certain conversation and what manner you may take to have that discussion. And it can all, kind of tell you how they feel about this certain situation and what they're going through. You need to look at how they would express their feelings. Some cultures keep to themselves. And don't share any emotion, whether it be sadness, grief, happiness, anger. And then others may put it all out there immediately, and you just you roll with it. You need to figure out where that person's at and what they are expecting, and meet them where they are. And so keeping all that in mind when it looks at their expression of grief. Some families, some cultures openly share their grief. They they may grieve physically. It may be more of an emotional aspect. They may keep to themselves. They may share it with everyone. So just being aware that just because someone may not have a reaction of grief the way you would expect doesn't mean that they're not grieving in their own way. So keep that in mind when you're having conversations with them. And so from the cultural standpoint, we can kind of look at some religious viewpoints on hospice and dying, to kind of look at certain things. Religious beliefs can greatly impact those views. What the expectation is during that time frame, if a person chooses hospice care, and whatever days, weeks, months they may have left, what are some religious standpoints they may encounter? Do they want to have conversations with people, or prayer, or certain ceremonies or rituals take place? So being aware of that, having conversations to gain that information, to ask what their expectations are, and again doing your own research. So if someone gives you some information that you're not familiar with, a viewpoint or a religious belief that you haven't heard of before, take the time to check into it, so you are, can ask questions and make sure that everyone's on the same page. So just to kind of look at certain things, to quote Dr. Amanda Mole from Johns Hopkins Hospital and Chaplain Matt Norrell in an article they wrote, an individual's religious beliefs may affect how they perceive death, the dying process, and the afterlife. So it's not just while someone's living that it's important to take note of what their religious beliefs and expectations might be, but to consider what they want done after they pass. At the time of death, there may be certain things that have to be done in a certain time frame, or certain rituals that need to take place. So being aware of what's going on. And that kind of takes me to this slide from the University of Arizona, their Center on Aging, offering tips talking about religion and end of life care. Identify their reviews or their views how it impacts their decision-making process, and be aware that just because someone identifies with a certain religion doesn't mean that they follow all the beliefs and customs associated with that religion. So again, having clarifying questions ready for them so you know what their exact expectations are. And also involving clergy if needed. If the patient and family are agreeable to it, seeking out clergy from their religious viewpoint to be involved in this process. It may be conversations, maybe prayer, it may be ceremonial process after death. So keep that in mind when you have these discussions about religion and end of life care. So on that note, I kind of want to dive into what you might encounter when it comes to end of life in certain religions. So the Pew Research Center in Washington, D.C. Did a study of adults in Illinois and found that 71% are of the Christian faith. So that means 36% are Protestant, 28% identify as Catholic, 1% Jehovah's Witness, and less than 1% are Mormon. We can look also at those that identify as part of non-Christian faiths, and that is 6% of the adults that were polled. 2% are Jewish, 1% Muslim, 1% Buddhist, 1% Hindu, and less than 1% belonging to other world religions. Also in this study, they found that 22% of adults do not affiliate with any religion. 15 say they don't follow anything in particular, 4% are agnostic, and 3% are atheist. And to round out the total, 1% say they don't know their religion and don't have a religious viewpoint one way or another. So I wanted to take a little bit of time to kind of talk about death and dying and some of those religions and non-religions that were mentioned in this study, just because it's something that as a hospice social worker, myself and my coworkers have encountered in addressing processes for death and dying under certain religious beliefs. So we'll kind of touch base on, Christianity. So in looking at Christianity, they have the belief that those who have a personal relationship with God will enter heaven once they die. And preparing for death, ministers and church members may visit the patient and family to offer support and assistance. That's prayer, could be sharing stories, discussions, testimonies, anything like that. After death, funeral services may be held at a patient's church or other location where a pastor leads the service. And the patient may either be buried or cremated, and family and friends visit the gravesite to mark special occasions. So being aware of a person's expectations, and what they would like during their time in hospice care and after they die, is important to consider. When we look at Catholicism, there's the belief of an afterlife, and once a person of the Catholic faith dies, they will be face to face with God. If they've not repented of a grave sin at the time of death, they may not enter into the full glory of heaven. And so having conversations with patient, if their expectation is to have a priest come and visit with them, offer prayer. There may be the sacrament of the anointing of the sick provided, or even communion provided. So being aware of if they have a parish they follow with, if there's a priest that they are familiar with and want to visit from, that's wonderful. You may be able to reach out and have contact with them, or if not, but they are of the faith but may not follow with a specific parish, there may be a priest in the community that's willing to reach out, visit, and offer prayer and have these sacrament or communion. So upon death in the Catholic faith, family and friends pray for the soul of the deceased and ask God to receive this person's soul into heaven. There will be a funeral mass to celebrate life. There could be scripture, prayers, hymns, family and friends sharing about the person's life, and burial with family and friends marking special occasions by visiting the gravesite. Another religion to consider is that of Jehovah's Witness, with their belief that the deceased go into a kind of sleep until God resurrects them, and those who gain entrance into heaven will live with God, and the vast majority of mankind will be resurrected and restored to paradise on earth. Church elders may visit the dying and have prayer and share scripture. A funeral service is typically held either at the Kingdom Hall, where they meet, or at a funeral home. An elder runs the service that may include sermon, singing, and prayer. The body may be cremated or buried, and friends and family may visit the graveside, to mark special occasions. Mormonism, we can look at their belief that the body and spirit separate at death. The spirit goes on to the spirit world before being reunited with the body, and judgment will then occur. There's a ward bishop in the Mormon faith, and church members, they may visit, offer support to the patient and family. And that funeral service after death is typically conducted by the bishop and viewed as a celebration of life for the patient. Cremation is typically discouraged in the Mormon faith, so the patient is typically buried. And again, friends and family may visit the graveside to mark special occasions. We can look at Judaism, and their beliefs vary based on whether the patient is of the Orthodox, Reform, or conservative Jewish faith. They believe they will go to heaven when they die, and the next world is considered the world of truth. A rabbi may visit with the patient, and a tenet of Judaism is that the dying should be left alone. So the rabbi may be called to visit with the patient, share with them. And at the time of death, the person's eyes are closed, the body's covered and placed on the floor, candles are lit, and the body is to never be left alone. The body is washed and prepared for burial by a special group of volunteers from the Jewish community. Jewish people may not be cremated or embalmed. So the body is wrapped in a white shroud, and a coffin may or may not be used. Burial takes place as soon as possible, and Jewish law states that each grave must have a tombstone. After of death, there is a period of mourning called Shiva, and a candle is lit for the patient, and this is when people offer condolences to the family and friends. When we look at those that are Muslim and of the Islamic faith, there are two types of Muslims, Shiite and Sunni. Customs and beliefs vary between the two. There is a belief that the soul continues to exist after death, and a person can shape his or her afterlife for better or for worse, depending on how they live. There will be a day of judgment with Allah, and until that judgment, the deceased remain in their graves. Muslims should be prepared for death at any time, which is why daily prayers are important, and the dying may wish to face towards Mecca. Upon death, the body will be washed and wrapped in a white shroud, and contact between the body and non-Muslims is discouraged. Males handle the deceased males, and females handle deceased females. The body must be buried within 24 hours of death, as they believe the soul leaves the body at death, and cremation is not allowed. There can be a funeral at the graveside with readings from the Quran, and women are not allowed into the graveyard. There is a 3-day period of mourning following death, and male members visit the grave daily or weekly for 40 days. After this time, male family and friends may visit with the grave and at the grave, and everyone remembers the deceased in prayer. When we look at Buddhism and death and dying, Buddhists believe in rebirth and that they will be reborn after death, and the goal is to reach nirvana and avoid the death and rebirth cycle. Monks and nuns of the Buddhist faith may visit with the patient and chant Buddhist scriptures to make the transition from life to death as peaceful as possible, so the person can find a happy state of rebirth. At the time of death, Buddhists believe spirit leaves the body, but it may linger nearby. The body is treated with respect so the spirit can continue on its journey to a happy state. Funerals tend to be a simple service, with the body being buried or cremated depending on tradition. Looking at Hinduism, Hinduism embraces many gods and goddesses, and each Hindu worships one or more of these gods. They do believe in reincarnation. Family and priests may visit with the patient, as well as sing songs and perform last rites and other rituals. At the time of death, the body is bathed and dressed in white traditional Indian clothing. If a woman dies before her husband, she is dressed in red. The body of the deceased is decorated with sandalwood and flowers. There may be a ceremony where scripture is read, and the body is cremated, as they believe burning the body releases the spirit. After death, a priest may purify the family's home, and 1 year later, shroud occurs, and that is a month-long event in which food is given to the poor in memory of the deceased. So those were the religions mentioned in that study earlier. So let's look at death and dying outside of religion. Those that identify as atheist. Atheism is not a religion or a belief system. They do not believe in God or multiple gods or spiritual beings or anything of the like. They may not like to use soul or spirit. They may say terms like consciousness and awareness. They might believe their consciousness will end at death and there is no afterlife. Some may prefer cremation over a traditional burial. Some may want a memorial service. If family members follow a certain religion, the patient may want scripture and hymn reads. Due to family beliefs, they may be all right with that because it gives family comfort. Others may not like this as they find it offensive as it is not a belief they carry. So it's important to have the patient talk about their beliefs and what they hope for in the death and dying process, what their expectations are through all of it, and what their wishes may be when it comes to funeral planning and final wishes. When we look at agnosticism, so agnostics neither believe or disbelieve in God or religious doctrine. They believe it is impossible to know anything about how the universe was created or whether divine beings exist. So again, it may be a similar approach when it comes to death and dying as those of other non-religious beliefs. So, and it's important to have conversations about the patient, learn what his or her wishes might be. And again, that kind of goes back to what I've touched on this whole time, talking with everyone, asking questions, learning about what their expectations are, and looking at end of life, funeral planning, and what they want, what they need during that time. So that kind of covers culture from a personal standpoint, and what everyone may think about when it comes to culture. Oftentimes values and beliefs, language, religion, that's what you consider. But one thing I would like to touch on here as we wrap up is the culture of death and dying in healthcare. So we often view healthcare as life-saving measures. Calling 911, calling an ambulance, going to the hospital with chest pain, having doctor follow-ups to maintain medicines, whether it be for chronic lung conditions, stomach issues, that sort of thing. You're doing that for a preventative measure, for life-saving measures. And it may be hard for some to consider hospice as an option due to the connotation and misconception that it is viewed as giving up. In some areas. There may come a time when someone wants to consider the quality of life over the quantity of life. It's important to note that having early discussions, providing education on what end-of-life care means, what those expectations are for each individual, can help provide a better understanding of hospice care, both in a private setting and in the healthcare setting, whether it be in hospital, doctor's offices, and the like. So having those conversations, being able to talk about what hospice is. Some may not even want to speak the word because they think about it being end of life, death, finality, and not the benefit that hospice can provide when someone does have a terminal illness in those last few days, weeks, months of life. So with that being said, I would like to bring in a coworker of mine. Her name is Melise Oakley. She is one of the community educators here with Hospice of Southern Illinois at the Marion office. So she is one of the ones that goes out, talks to members of the community, healthcare providers, to kind of provide insight and information into what hospice is. So I will turn it over to her.
Thank you so much. Again, my name is Melise Smith Oakley, and I'm with Hospice of Southern Illinois. And I'm here to talk to you about something you probably don't want to talk about. When I reflect on my life, I know that we plan for graduations, weddings, births, retirements, and everything in between. But what we don't want to talk about and plan for is death. And as human beings, we have a terminal disease, and it's called mortality. The current rate is 100%. Worldwide, every second, 3 people die. Every minute, 180. Nearly 11,000 people die every hour. And that is over 250,000 people a day. Now, I'm going to start by saying, while I was watching a documentary on a PBS channel, and it was a narrative, and the narrative, he was a doctor, medical doctor, and also a reporter. And I was struck by his comment because he said there are only 2 unfixable things in life, and that's aging and dying. So what I want to talk about today is our unfixable. When a family member enters into those unfixable areas of life, then that's whenever we step in to help your family. We must think about this because it's going to happen. We are not about giving up. We are shifting care, and we are all about living. So I always like to tell people, let's pretend like we're journeying to Switzerland. What do you need? You need maps, you need a language translator, you need currencies, you need guides, you need local transportation, travel guides, research into the culture, get the climate, weather, just to name a few. These are all things that you will need to correctly navigate in a foreign country. This is our job at Hospice of Southern Illinois. We are your tour guides. Some of you have already shut me off and don't want to think about these things. And I remember my mother always trying to tell me about what her dying wishes were. And before I had this job, I didn't want to hear it. And she would always tell me she wanted a closed casket. And I would actually put my fingers in my ears to drown out her voice. And I just would say, stop talking about it. And she wouldn't. And so she likes her makeup, she likes her eyelashes. And I told her if she didn't stop talking about it, that I was going to take her, once she has passed, down in a convertible, prop her up on Main Street and have everyone view her. And that would quit her talking about this. But since I've worked for Hospice of Southern Illinois, I now ask my mother all kinds of questions. The reasons we do not want to talk about hospice is because of the myths that are out there. Things that we've either heard of or that we think we know. So I'm going to talk about just the most common ones. The one that I get a lot is hospice means giving a patient a pill of working. And this is the farthest from the truth. We had someone that was in the healthcare profession, and he came into our program, and he believed this. But our primary goal is to relieve the symptoms, control the pain, and give patients the peace and the dignity for the end of life. The other thing that I've gotten before is a lot of times hospice and palliative care are used in the same, and they are not. So palliative care, I just try to tell people that is when a patient is seeking aggressive treatment, like chemotherapy. Hospice is comfort care, and we're treating the symptoms. So a lot of people get those two words confused, or they use the same word and they're not. The other thing is they believe that hospice care is for people that only have a few days or weeks to live. And I love this story because last year we granted a wish for a family that was in our services. The patient always wanted to go to St. Louis Aquarium with her family. So we were very honored and gracious to have our community come together and get donations to make this happen. We got 2 days for this family to have hotel rooms downtown St. Louis and 6 free tickets to the aquarium. The other thing was we were able to get 1 vehicle for them all to go into and travel to St. Louis. A lot of people don't realize that people are still moving around and that whenever they're on our services, but people are able to do and still live with hospice. The other thing that we get a lot is that hospice is very expensive, and it is actually less expensive than your care provided in a traditional medical setting. Medicare, Medicaid, and most private insurance cover the cost of hospice care. I also have a lot of people saying that hospice happens just in a hospital or a facility. And hospice can happen wherever the patient is located. We have had people in our services that we have met on Walmart parking lot. We have had people in camping and outside. And so we will go wherever that patient is and whatever they want. And that is the main focus, is we focus on the patient. Some people always say that once you decide you are on hospice, you could never go back. Well, we have had people or patients in our program that have entered into the program at 90, and then they get released for some reason. They don't meet our criteria, they get better, and they re-enter into our program. And that happens. It does happen, not a lot, but it does happen. The seventh one is only a doctor can refer someone to hospice. And that is not true. Anyone can refer a person to hospice to start the process. Now, we will need the prognosis of 2 different doctors, but anyone can start this. You just call our office. We'll give you informational. We will give you the information to make the best decision for the patient. And that is what we focus on, the patient. Hospice care ends with the passing of a patient. A lot of people don't realize that our bereavement counselors remain in contact with the family and caregivers for 13 months following the patient's death. Our counselors and the bereavement department can personally visit the patient, the loved ones, listen to the stories, answer questions, provide information. And, we all grieve differently. And these professionals are equipped and can answer questions and help to find resource to help the grieving process. The other thing that I think is awesome is that hospice care only benefits the patient. This kind of follows along. It's not. It's focused on the patient and the family and the caregivers. A lot of times the caregivers need to cope during this time of transition, and we want to provide help and for the family unit. And the bereavement department, the counselors help, and they understand and have possibly walked through it through themselves. And also they feel like they do it probably with their families and getting to know them and counseling them. They are there to offer grief support before and after loved one's death. This is another thing. Hospice does not provide caregivers. We have a list of caregivers that we can suggest, but we do not do 24-hour to provide care. We are, anytime that you need, if you're in a crisis or is an emergency, you can either talk to someone, or depending on the crisis, they will come to you. But we will not have someone stay with the loved one until, so it's just what we like to say is we provide an extra eyes and hands for the person to just evaluate what's going on and being able to focus on the patient. If there is one thing that you could take from me today about my talk, is talk to your family about your wishes. Do not be afraid to talk about the unfixable with your family. These discussions should be happening when everyone is involved and thinking clearly. This does not need to happen when you are in a crisis mode. We see this so many times in our services. People have not spoke about it, so talk about it. In my family, we used humor. But I always like to say hospice is hopeful, it is helpful, and it is relief, knowing that you do not have to do this alone. It is a way of navigating the unknown with someone by your side. You have the whole team by your side. We nurture the emotional, the physical, and your spiritual needs. Hospice of Southern Illinois are angels on earth, and we are about living. Okay. have it over to Jarod.
All right, thank you, Melise. That kind of wraps up the presentation portion. I know we had someone monitoring through to see if there were any questions or anything may come about. So at this time, if anyone, does have questions or comments, would like to share some information, please don't hesitate. Let us know. Again, I think it's just important to remember that all of this is a conversation, whether it be about healthcare, hospice, anything in life. When you're working with someone, it's important to have conversations. You need to know the expectations. You need to know what someone wants out of their time with you. So be sure to see them as an individual and take their thoughts and perspectives into consideration when you are working with them.
Jarod, thank you. And we are monitoring. So if anyone has any questions, we can make sure to get them to Jarod. And I will say this, if you think of something, you know how oftentimes we go to meetings, we have a conversation and go, oh, I wish I would have thought of that. If you send something to us, we will definitely get it to Jarod and make sure he has an opportunity to respond. First of all, Jarod, thank you for your awesome presentation. And I hope Melissa's close because she did a great job too. Again, everyone, I'm Lisa Phillipson, the Community Relations Director for Hospice of Southern Illinois. We are so glad you're all here today. And in your inbox, you should be receiving the survey that we need you to fill out. And we appreciate you taking the time to do that. Remembering that the CEs will be generated from that. So we just need you to do that so you'll get your CE in a timely fashion. We also need you to make sure that you know that we're having a social media contest right now. You check Facebook for details. It ends next Wednesday. For Apple AirPods, our Tavern on Main gift certificate, a Casey's gift card. So a lot of things for this contest. So go to our social media page, Facebook, and check out for our contest. Also, as we grow our social media platforms, we are now in social media influencer collaboration on our Instagram page, and we invite you to go to our Instagram page. Jarod, we're just moving forward with all social media platforms. We're into influencing now. Our next to see online is with our very own Lisa Simonin, who will be presenting Managing Grief Year-Round. And Jarod probably knows this firsthand, especially during the holiday season. Again, we appreciate you all being here with us today. Remember, Hospice of Southern Illinois, ask for us by name. Always remember, Hospice of Southern Illinois. And I'm going to end with this. October is my favorite month, and I'm so glad we live in a world where there's October. Again, we're going to stay open for just a few more minutes, but those that you want to move on about your day, you're welcome to. Thank you again from everyone at Hospice of Southern Illinois. Wishing you a beautiful fall season, and we'll see you in November. Bye.
Thank you.